All right, it gives me great pleasure to welcome Linda House, our Harry E. Hines Memorial Lecturer. Linda has deep roots in the cancer community, serving as an oncology and as a hospice nurse, then as an executive at Eli Lilly and Company for over 20 years, then serving as head of cancer care at St. Vincent and Indy, and then landing at Cancer Support Community, the world's largest nonprofit provider of social and emotional support for anyone touched by cancer. Through an affiliate network of nearly 50 centers, a series of satellite locations, a full suite of online services, and a telephone helpline, the CSC network delivers nearly $50 million in services at no cost to patients or their loved ones. As president, Linda leads the marketing, communications, development, and public policy functions for their headquarters organization and is also accountable for research in the Research and Training Institute. Linda, welcome to you, and thank you so much for speaking.
Well, thank you all for having me. It's particularly meaningful for me to be here today, and I'll tell you why in just a second. But I want to make sure that you guys have energy to roll with me, because I sort of feel like that cartoon that you said, if you think this is hard, you should see what's in my head. And I actually did an ad board today from 6 to 8 this morning for 2 hours to have somebody say to me, "You've just rewired my thinking. You've rewired my brain to think in a different way." So I want to make sure your energy levels are up. A number of my patient advocacy friends are here in the room, and I thank you for being here today, and I'm hoping that I get an amen sister from you at some point in time during this particular talk, so I'm counting on you for that. I want to start off with a thanks. I feel like it's really important to take just a moment of reflection. I'd like to thank Dr. Mark O'Rourke, who my friend is sitting here in the front row, for bringing me here today. And I was invited, and then I really learned the name of this lecture, and I started to really think about Dr. Harry Hines and really appreciated some of his teachings. In particular, this particular quote stood out to me, and that terminally ill patients and their loved ones deserve the highest quality of care. And I remember when I was running the cancer center saying to the folks who did sort of the routine things like the radiation therapy, folks, look, you're going to see 35 people today. You're going to put people on that table, put them in a gown, take them off the table 35 times today. You know how many times they're going to see you? Once, right? One time. Make it worth it for them. So I really appreciated those teachings. And then on a very personal level, I lost my dad to AML this summer and realized that this is how we lost Dr. Hines, and feel like I'm really honored to be here today in both of their memories. So thank you. So the cancer support community, a little bit of a background you heard in this generous introduction. Thank you so much. But we really do operate under these 3 pillars, which is to make sure that patients are empowered by knowledge, strengthened by action, and sustained by community. We're 35 years old this year, so you'll see a lot of green in what we're doing. We're taking advantage of the Emerald Anniversary, which stands for hope. So you'll see differences in our logos, and we were joined by Joe Biden at our gala last week, which sort of elevated the 35th anniversary celebration. The way in which we operate, just to give you a little perspective, we operate under 3 pillars that match our mission statement. The oldest and the heart of the organization is our service delivery arm. We are the largest employer of licensed mental health professionals for people with cancer in the world. We do one-on-one counseling, we do support groups, we do educational meetings, we do research in our brick and mortar facilities as well as on our telephone helpline. The next oldest pillar is our Research and Training Institute. It's led by a PhD clinical psychologist who's also a 2-time cancer survivor, and we have a suite of PhDs who support her. We contract for special needs, so if we're doing qualitative research, for example, we have a woman who's a medical anthropologist and a linguistics expert that helps us with that. The design of the Research and Training Institute was to, in fact, become the experts in the cancer patient experience. And we've been able to do that very successfully through a couple of very large databases that outline the cancer patient experience, one of them being a cancer experience registry where we have 12,000 patients constantly sharing information with us about their interactions with you, their financial toxicity, what's happening to the family unit as they go through this particular journey. We also have one of the largest databases of cancer-related distress information in the world. So all of our affiliates are now screening for distress. We have a validated distress screening tool that's also being used by a number of institutions. And that information is rolling into the Research and Training Institute, which allows us to bring to you some of the insights that I want to share with you today. And then finally, we have a Cancer Policy Institute, and I have very late breaking news as of about 2 hours ago that I'm going to make you wait until the end of my presentation to hear. So why am I here talking to you about innovation in survivorship research today? I like the word upheaval, right? Because I think about we are on the cusp, not only in Washington, D.C., but just in our experience with patients of really this true upheaval. Part of that is being driven by the fact that the average age of a cancer diagnosis is somewhere around 65, and the lead edge of the baby boomers is around 68. So you think about, we're getting ready to see a whole, not in addition to the swell, we're seeing a whole new generation of people who think, act, and believe differently. And one of the things that I talk about when I just saw some OCM data, and for those of you who are part of the OCM network, I know that you've just gotten your first 6 months of data. You think about the big data sets that help you sort of predict the way in which patients or tumors will respond. We heard great information today about genomic testing. So we have big data sets. This is how physicians are prescribing. When you look at genomic markers, this is the likelihood of people responding. When you think about what's happening in clinical practice, here are the stats of the first 6 months. What's missing from all of those that really has the ability to tip the scale, this is writing my advocates, the patient and the patient experience, because nothing can destroy those numbers more than attitudes, beliefs, and behaviors that take patients off course. Okay? These numbers, you know them. We have, for those of you who are going to play along with me, what is the first number? Any idea? 1,000,006? Great. New patients diagnosed with cancer, 15.5. Survivors, 67%. 5 years or more. Survivors living 5 years or more, 17%. 20 years or more. So you see the demographics are shifting in a way that we've not ever known before. So people need us. That's the bottom line. Patient perceptions have changed. They've changed for the better when you think of clinical research. So we've held large-scale patient summits on clinical trials and launched a large-scale patient education program called Frankly Speaking About Clinical Trials alongside Moonshot in this last year. And we started all of that with patient-level research. What we didn't want to do is sort of say, okay, we're going to go top-down and tell patients what they should know about clinical trials because it's tried and failed. Teaching them this is a phase 1, phase 2, phase 3, phase 4. What we wanted to say is, okay, let's bring a group of patients in who have been in a trial, patients who haven't been in a trial. What made you participate? Why didn't you participate? What materials would have helped you participate? What did help you participate? And really think about creating a patient education platform and a whole suite of services from the ground up. So what you see on the screen here are the results of some of the testing and some of the qualitative work that we've done that we've now backed up with quantitative. And I can make all of this available to you at any point in time if you're interested. But you can see that their perceptions have changed. They sort of understand now what a clinical trial is all about, right? We're learning about new treatment options, better ways to treat the cancer, tracking people over time so they even understand longitudinal testing. It's great news. They understand this whole clinical trials piece. But some have not. We've repeated this study in our cancer experience registry with patients with metastatic breast cancer. These are patients with all diagnoses, but the information is the same. They still worry about randomization, they worry about placebo, and they worry about being a guinea pig, So somebody asked me the other day, and I started my career in 1984, and somebody said, well, how have patients' attitudes and beliefs and behaviors changed about clinical trials? And I said, they haven't, right? They haven't in these core areas. However, the good news, some have changed, and some are new. So when we look at some of the new concerns, we see a lot around financial toxicity and logistical concerns. When you look at women with metastatic breast cancer, which I think arguably are the most highly educated of patients with cancer because they're living with their disease, they're looking for that next solution, they've got this groundswell of fantastic advocates who have been around them from their diagnosis. Highly educated women, we lose 22% of those women to clinical trials because they fear they can't fulfill the logistical requirements of the trial. Think about that. Less than 3% of the patients going into trial, and we lose 20% of them right off the bat. Let's talk about the Belmont report. Does anybody remember when this was issued? 1978. 1978. And we've been visiting this report with the FDA a lot over the last couple of years as we've been talking about what I'm going to bring to you in just a second from a new innovation perspective. But take a look at the words that are outlined in red, that I've turned red. Risks, there are, for example, risk of psychological harm, physical harm, legal harm, social harm, economic harm, and corresponding benefits. Okay? The very last words, other possible kinds, should not be overlooked. So what do we mean by that? Let's talk about the patient experience in today's world. This is an eye chart, I know that. And again, I'm happy to provide the information to you. So our distress screening tool is a 25-item and a 15-item distress screening tool. It's validated in a number of areas and has a depression subscale as a part of the tool. But we were asking patients, okay, rank order your levels of distress on these 25 items. And we really took a look at what are people, frequency, right? What are people most frequently telling us that they're most distressed about? Hands down, diet and nutrition. So if you want to know how to provide a blanket resource to your patient, diet, nutrition, that's what they are. Frequency, the most patients concerned about. We applied a discriminatory index to this 25-item tool and really took a look at which of these items would have the highest probability of causing patient harm, and in this case, a clinical diagnosis of depression. When you think about what rose to the top here, number one, you'll see that diet and nutrition fell to 24 out of 25 on the list. But what really rose to the top here and got our thinking about how do we really look at what we're doing in clinical trials and thinking about experience differently is disruption to work family life. So think about that. Disruption to work family life, 92% probability of causing a clinical diagnosis of depression, which, by the way, from a societal consideration, costs the system $8,400 per patient per year more than a cancer patient who doesn't have depression. So think about that in the context of our new value frameworks and where we're moving. Clinical trial endpoints. We continue to focus on traditional endpoints. Overall survival, progression-free survival, quality of life, typically based on a defined set of patient-reported outcomes, disappearance of the tumor, right? Disappearance of the tumor. And one of the comments that I made in my call today is we have to stop focusing only on the tumor. We have to focus on the host and the response to the overall experience. So what am I talking about when I talk about patient experience in clinical trials? We spent a lot of time with the FDA on this. We spent a lot of time with the NCI. And the breaking news is what we're doing on Capitol Hill, but I'm going to make you sit on that for a minute too still. It's going to be good, though, I'm telling you. Current patient-reported outcomes still sort of focus on the body, right? The bioscience piece of the experience. The FDA definitions are disease symptoms, treatment side effects, and physical functioning. What we believe and what we would like to see as we think about rewiring your minds, because you have the power to deliver this, right? This is why I'm so hopeful. You all have the power to deliver this, is starting to collect patient experience outcomes. So moving from what am I doing to the patient, how are they responding to it physically, how is this really impacting their life? And if you think about being able to spend a little time up front on better understanding this and intervening in a way in which would be meaningful, spending less time on the back end trying to find patients who are lost to follow-up in your clinical trial design, right? So when you think about efficiency, that's sort of the what's in it in the short term. When you think about what you could deliver to this conversation in the long term, it's the ability to make decisions based on the entire patient unit. Not only in your clinic, but when you're sitting at ASCO looking at their framework, right? Their value framework, which, by the way, is 80% weighted to the tumor and only 20% weighted to the way in which the patient is experiencing their cancer. Think about that. When we have studies that say it's the complete opposite for patients, they care more about quality of life than they do about length of life. So just sit with that for a moment. You know, when you think about the NCCN evidence blocks, being able to elevate this new information about the way in which people are living with their cancer. When you think about ICER making real decisions on how you're going to be reimbursed for care and whether or not patients have access to treatments, being able to elevate this new body of evidence to them in a meaningful way. So think about that as you move forward. How do we do this, right? Have to be included in trials. Not all trials, but the majority of trials. These metrics have to be specific to a trial. So I'm not saying take our 25-item tool, take our 15-item tool. I'm not saying that because it's way too much. I understand what it's like to be in the clinical trial setting. I'm saying one well-placed question, right? One well-placed validated question. And I'll give you an example. I remember taking GemCis forward in bladder cancer versus MVAC, right? So it's a time of all poisons, 4 poisons versus 2 poisons. And the outcome was non-inferiority, but the toxicity difference was so different that it swung standard of care, and many of you in this room worked on that trial. So you think about what I just told you about disruption to work-family life and adding that into that clinical trial design and understanding that better from the patient perspective. Or you think about some of the immuno-oncology trials that are ongoing today, and I had one of the head researchers from one of the companies come to me and say, hey, Linda, how do you think patients will respond if our solution is a once-a-week solution when our competitor is an every 3-week solution? I said, well, I'm going to tell you what patients are going to think, given the data that we have, right, is that they're going to have to now come in from work once every week. They're going to have travel expenses once every week. They're going to be exposed to toxicities once every week. So you've now sort of added that burden to their disruption work-family life. I said, but you know what? You might not just want to ask me, you might want to ask their payer, because you've just now created a situation where the patient's 3 times more expensive than your competitor, right? So just think about that. And then we have to document and report it, because other than that, if we don't do it, we're going to hear the things that we hear now, which is, well, we don't collect that information in a randomized controlled clinical trial, therefore I can't include it, which was a very real conversation that we had with ASCO in the frameworks talking about neuropathies in people who have received taxanes. It's not collected, therefore we weren't going to use it in our decision making. So why do we want to do this? Improve patient outcomes. We haven't even talked about it, but there's a study done by Barbara Anderson at Ohio State in women with breast cancer who went through a support group every other week for 1 year. She followed them for 13 years. Patients who went through the intervention arm had a 1.5-year survival advantage over those who didn't. Patients who went through the intervention arm had a 50% reduction in risk of developing a recurrence, and of those who did recur, a 50% reduction in risk of dying for their disease. So you think about applying this type of standard as a part of your general care, there are real patient outcomes in that. Reduce clinical trial abandonment. We've had a time when we've got 50% reduction in, or 50% abandonment rate in clinical trials, and then providing meaningful information for treatment decision-making, like I'd outlined for you. So how do we do this? It doesn't sound so easy, and it is not easy. It's not easy, but we don't have a choice. We have to do it. The idea would be you enroll the patient in the trial, because we don't want to suggest that there's any sort of trial bias. Somewhere around visit 2, when they're over the shock and awe of their consent process, we take them through a routine screening. We do rescreening. All the while we're monitoring and documenting interventions for them. So what are we doing? What is we as the cancer support community doing? In addition to coming to meetings and interacting with the greatest minds in science, which in fact, Dr. O'Rourke, I did tweet yesterday about being here. We are working on a proof of concept study. You know, how do we really embed it, and what do the mechanics look like? We are continuing our dialogue with the NCI, the FDA, and additional researchers. And here's the late-breaking news. As of 2 hours ago, the Patient Experience in Research Act was introduced in the House of Representatives by Diana DeGette and Leonard Lance. And this particular bill, it's the cancer support community's first bill introduced. This particular bill was designed to run alongside the PDUFA reauthorization. So PDUFA is the Prescription Drug User Fee Act. It funds about 70% of the FDA's activity. It's up for reauthorization this summer. And in the current letters of agreement, and this is really important to you because perhaps you would be able to work with industry to get some of these funds, but in the current letter of agreement, there's a mandate that FDA does pilot studies, right? So some of the PDUFA money has to be used for pilot studies. So the language of this bill essentially says that the FDA must do a patient experience in clinical research pilot study with no more than 3 pharmaceutical companies. We wanted to cap it so that it wasn't an expensive experience, but to really start to capture these patient experience metrics as a part of the FDA process. So 2 hours ago, that bill was dropped in the House. We will have a bill number on Monday, and I'll be reaching out to a number of you to help us support and move that forward. And with that, I'm going to close, and I'd be happy to entertain questions now or later.